We are live.
All right, so good evening, everyone. And on behalf of the Video Retinal Society of India, let me welcome you all to our next surgical grand rounds. As you know, we have started these grand rounds, which are held on the fourth Friday of every month. And every time we deal with either a medical, surgical, or an imaging topic. So today we have a very interesting lineup of cases and talks. And the theme for today is unraveling tractional retinal detachments. And I have with me my co-moderator and friend, Dr. Mohit Dogra from PGI Chandigarh, who will also be moderating the session along with me. And we are very fortunate to have with us as our guest speaker, our distinguished faculty, Dr. Mahesh P. Shanmugam, sir. Sir needs no introduction. He's been a teacher and mentor and guide to all of us. We have learned a lot from him. And he will be talking about tips and tricks in TRDs. We also have three very interesting cases which will be discussed by our three esteemed discussants, Dr. Rohan Chawla from AIMS, Dr. Alok Sen from Chitrakoot, and Dr. Devkan Mishra from Swanjyoti Hospital. And three vice counsel, Dr. Malika Goyal from Hyderabad, Dr. Ramandeep Singh sir from PGI, and Dr. Subhendu Bural sir all the way from Calcutta. So without much ado, may I please invite Dr. MPS sir to kindly share his slides and teach us about tips and tricks in TRDs.
Thank you, Dr. Mudit, for the kind invitation. You can see my slides now.
Yes, sir.
Good evening, everyone. So we'll be speaking about unraveling traction retinal detachments. And most of the cases I'm going to discuss here are diabetic traction retinal detachments. So let's get into how we manage traction retinal detachments. The dictum I follow as far as diabetic traction retinal detachments is the more fundus details one can see, more difficult the surgery. So whenever I can see most of the fundus details, then I know that this patient surgery is going to be difficult, and we need to plan for the same. What it means is that there is no posterior vitreous detachment. When the posterior vitreous detachment is there, that usually results in a subhyaloid hemorrhage or a vitreous hemorrhage, indicating that there could be separation of the hyaloid somewhere, and we can start the surgery from there. But if in case we are not able to see the details, then that means like there's no hyaloid separation, and a lot of dissection would have to be done. So let's start with one case example. This is an easy one with no posterior detachment and shallow traction detachment. It's a young patient and a fairly recent history. So this is how it looks like. We can't see the retina. The blood vessels, what we see are the blood vessels within the fibrous tissue proliferation. We can't see the disc as well. So the whole posterior hyaloid is stuck to the retina. And so we are trying to use a needle to see if we are able to induce one area of traction, like posterior hyaloid separation. So here we have incised the posterior hyaloid separation, and we can see the subhyaloid hemorrhage moving when we lift up the hyaloid. So once we enter there, then we circumcise it. That is, we do the peripheral truncation, and I usually use a foldback technique. And once that is done, we can see that this retina, which looked as though it was inoperable, is actually very, very healthy beneath. And this whole posterior hyaloid is the one which looks like a fibrous tissue proliferation, which was peeled off most of the areas. And wherever there are vascular nails, then we dissect with the scissors. And usually the last part of the dissection is the one which is usually more difficult. And I usually prefer to use scissors to dissect this. So what do we learn from this particular case? Younger prolif. Younger prolif in the sense a recent onset traction retinal detachment in a younger patient usually comes off easily because the fibrovascular nails are still not fibrosed. And so it kind of peels off when we peel or do a foldback dissection. But the downside is they can bleed. So we need to be careful as far as the bleeders are concerned. And graded truncation. I usually don't like to hold at the disc and pull off the fibrous tissue proliferation and cut. So go 360 degrees, a truncation of the cone. So a foldback technique gently induce the PVD 360 degrees and then work towards the posterior fold. So here we saw peeling with the forceps, foldback with the cutter, and then cutting to induce the posterior detachment and then work posteriorly. As I mentioned, I prefer outside in most often. So the key in diabetic traction retinal detachment is to look for the second membrane. So what we see here is the second membrane, but this is the obvious fibrous tissue proliferation. But what extends beyond that is the vitreoskitic membrane, which we call the second membrane or secondary membrane. So it's preferable to identify that and work underneath that. So if you work underneath that, then the risks of a retinal break or bleeding are much less common. And you can see the whole fibrous tissue presents itself to the cutter as we dissect. So we don't have to use any special instruments in this case. You can see once we like induce the secondary membrane dissection, then the fibrous tissue proliferation presents itself into the cutter. So what do we learn? The second membrane is actually the vitreoskitic membrane, which is attached to the retina. And what is visible is the fibrous tissue proliferation, the fibrosing proliferation, which is lifted up into the vitreous cavity. So how do we suspect that there is a second membrane? Most of the diabetics will have a second membrane. We find that the edge of the proliferation is not lifted into the vitreous. Though it may look as though it's lifted up, when we try to get to the cutter inside, you can see that the cutter or the scissors doesn't go underneath that, indicating that there is another membrane which is going onto the surface of the retina, much beyond the visible fibrous tissue membrane. And we have to look at that and then start peeling it towards the visible fibrous tissue membrane, and that's the correct plane of dissection. And dissection beneath the second membrane is the correct plane, and it decreases the bleeding and breaks. If we just operate on the visible fibrous tissue, what happens? The second membrane keeps the blood vessels open. So the bleeders continue to bleed. And even if we cauterize, what happens is the skytic vitreous, which is around the blood vessel, keeps the blood vessels open, giving rise to continued bleeding. And the cautery is not very effective. So we need to work underneath the second membrane. And once we remove the second membrane, what happens is the traction on the blood vessels is lesser, and the blood vessels also stop bleeding over time. And the risk of breaks is also much lesser if we operate beneath the second membrane. Let's look at another example. This is a 70-year-old one-eyed gentleman. He had 612 vision when he presented to us. So he has this lamellar hole and a paramacular traction retinal detachment. And though it is tempting to operate, the other eye is no light perception, and there's 612 vision, and he is pretty much ambulant. And we just followed him up. And 4 years later, what happened was he complained of vision loss. So what we see is the traction, the flat traction has increased, giving rise to a schisis. And though the traction retinal attachment, what was there earlier, is the same, but the fovea now has a lot of schitic areas. In addition, he has got loss of vision. So this is how he looks like. So as I mentioned, the more retinal details we are able to see, more difficult the surgery. And you can see the vessels are all pretty much attenuated or sclerosed, and the disc is also pale. And the fibrous tissue proliferation is flat and mid-peripheral. So if it is beyond the arcade mid-peripheral, these fibrous tissue proliferations are again very difficult to dissect. And this area of the retina is thin, ischemic, and is likely to tear very easily. So let's see how we go about doing the dissection. If I remember right, we gave autologous blood. That is the blood what we can see. So we are trying to see where, if we are able to induce one area of like PVD, and here we have opened up the hyaloid and we are injecting viscoelastic underneath that to create a pocket of PVD. Didn't work too well in this particular case. Then very gently peel off the vitreous circumferentially. We don't want a retinal break in this one-eyed gentleman. So you can see the fold back technique. And 360-degree, you can see the proliferation is completely flat. So if we try to pull it off, and this is being an ischemic, long-standing traction retinal detachment in ischemic retina, it can tear very uncontrollably. And if you have not dissected the fibrous tissue proliferation, and if you have a break, and if the retina becomes bullish, it becomes extremely difficult to manage these patients. So very gently, we are peeling it off, and you can see there is a LHCP at the macula. And as much as possible, we are trying to see if we are able to manage unimanually. And at that comes a point, then we are not able to manage unimanually, and we switch to a bimanual dissection. Unimanual dissection can be done for the peripheral formed vitreous where there is no thickened posterior hyaloid like a fibrous tissue. So there we can do a unimanual dissection, and then we proceed with the bimanual dissection. So here you can see all the fibroscal nails are what's happening to the video. We induce the posterior hyaloid detachment and remove all the fibrous tissue. There are no retinal breaks. And this is the LHCP which he had as well, and then fluid air exchange. And though there are no retinal breaks, we decided to use silicone oil in this particular patient because he was a one-eyed patient, and usually they do have some amount of bleeding in the postoperative period. I want him ambulant. That's the reason we have used silicone oil. So this is what we started with, and this is what we ended with. And you can see post-operatively, the skytic macula and skytic retina has settled down, and the tractional detachments also settled down, and his vision improved. So what do we learn in this patient is not all patients with a parafoveal tractional detachment, we need to jump in and do surgery. So in this particular patient who was one-eyed and who was pretty much able to carry on with his activity, and a completely plastered hyaloid, thin atrophic retina, ischemic, best is to watch until there comes a time when we are forced to intervene. So we did watch for about 4 years before we intervened in this patient. So visco dissection can be done. So create a small opening in the hyaloid when the hyaloid is completely plastered, and very gently inject viscoelastic through that, and it kind of separates lifts the hyaloid, allowing us to do the surgery, dissect the fibrous tissue from the fibrous proliferations. And I also found that the LHCP can occur in TRD from this patient. So moving on to the third case, and this patient, the fibroscopal proliferation looks pretty much avascular, but here you can see the second membrane very, very well. You can see what I'm using is the needle. You can see this glistening membrane, which is extending much beyond the visible fibrous tissue, is the second membrane. And so you can see this is what is, it's extending pretty much beyond. So we identify that, then lift it up. And once we identify the second membrane, lift it up, then it's easier to localize the fibrovascular nails and then dissect them. So bimanual dissection. So it looked very much avascular, but you can see the degree of bleeding which we have. And here, once again, you can see the second membrane, which is pulling up the macula onto the disc. So we start superotemporally and then dissect inferonasally. And every fibroscopal nail is dissected with the scissors. And these are patients I wouldn't want to pull off from the disc and then start operating, because we can have an uncontrollable bleeding from the posterior retinal vessels or a tear. So the clot is managed now. So what I would usually do is to manage the clot at the end of the surgery. So gently lift up the clot, and the bridging clot between the two fibroscular nails is cut, and the little blobs of clot are left behind on the bleeders. There was no break on the nasal side, but like this was an area of thin retina, which was lasered and the silicone oil was used. So what do we learn from this patient? Avascular appearing prolif can also bleed profusely, particularly if the systemic status of the patient is not appropriate. If the patient has nephropathy, hypertension, or the patient is on blood thinners, or if the patient has anemia, despite it looking avascular, they can bleed. So I would usually use anti-VEGF in these patients prior to surgery. So when do we cauterize? Most people do suggest that you cauterize immediately as the bleed starts. Why I don't do that test? Because of the caveats. Caveat is like if the cautery is not controlled, then you can have a retinal break. And we have not yet finished with the dissection, but if you have a retinal break, the dissection becomes difficult. So that's one of the reasons why I don't cauterize right away. And if you pull out whatever instrument we have inside, say from the scissors or a cutter, and then introduce the cautery inside, that gap can cause the blood to disperse inside the eye, make the visualization difficult, and that little hypotonic can also increase the bleeding. So I usually cauterize at the end of the surgery, or allow the blood bleeding to stop, and then, as I showed you, create the small pockets of clots over the bleeders. So moving on to another next case, which is a patient, once again, a one-eyed gentleman, very thick fibroscopal proliferation. You can see the sclerosed vessels indicating gross retinal ischemia and completely plastered hyaloid. You can see that like here we are inducing the hyaloid separation. You can see the retina moving wherever we are inducing the PVD in the periphery, despite which we are not able to get a great cleavage plane, but somewhere we're trying to use the needle to see if you're able to open up the hyaloid. Finally, temporarily, we're able to open one area of the hyaloid separation. In this patient, we had given autologous plasma, autologous blood, and TPA to create autologous plasmid, as well as preoperative anti-VEGF. And once the hyaloid is opened and then we have truncated the cone, then we start dissecting posteriorly. And once the clear vitreous or the clear part of the hyaloid is separated, then the thickened fibroscular tissue is dissected with the bimanual dissection. Once again, you can see a thick sheet, but it's not attached in multiple areas in the posterior pole, and we are able to remove the hyaloid quite well. And you can see underneath that possibly a functioning retina. And as we induced the PVD, he did have a retinal break in the periphery. And because there was an area of lattice degeneration and the retinal break happened, and we reattached the retina and used silicone oil in this patient. So what we learn from this patient is that, like, I do use adjuncts, and most often it's anti-VEGF, except in cases of vitreous hemorrhage, I don't usually use anti-VEGFs. In patients where we are able to see the fibrovascular proliferation, which is very vascular, then I would use anti-VEGF about 2 days prior to the surgery. And autologous plasmin, not in all the patients, but in eyes with globally adherent vitreous, like the patients I showed you, and a very thin atrophic retina, which is likely to tear, you would usually use autologous plasmin. And the key to dealing with these patients is entering the subhyaloid space. So I would usually incise with a sharp instrument like a needle. And once we enter the posterior hyaloid, then may use viscoelastic to induce a small pocket of posterior hyaloid separation, and then go about truncating the cone, gradually induce the PVD 360 degrees and work posteriorly. So breaks may happen. So what do we do when breaks happen? So here we can see once again a plastered hyaloid. So here we are able to induce the hyaloid separation nasally. You can see that the needle is going inside between the hyaloid and the retina and creating a kind of a tunnel through which the cutter is insinuated and the hyaloid separation is done. So here we use forceps in some areas, usually use forceps to peel the fibrosal proliferation over the disc, and rest of the areas, and you can see it's being peeled off from the macula. It's try to peel and see, and wherever you find vascular nails and if they are strongly adherent, then I would stop peeling and use scissors and forceps to cut. So here the foldback technique is used, and superiorly is where the fibrous tissue is like strongly attached and there is area of retinoschisis. And as we are peeling it, you can see a retinal break happens and the skytic retina gives up and there's a retinal detachment. Fortunately, this happens towards the end of the surgery. But if it happens towards the beginning of the surgery, then it becomes a bit difficult. So what I would do is to stop operating in the area of the break, go to another area and work towards the break. So when there is a break in the early part of the surgery, it becomes very difficult. We should not allow the retina to become bullous. If we allow the retina to become bullous, it becomes extremely difficult. We may have to abandon the case as well. So once a break happens, if there's a bleeder, we need to cauterize it and move away from the break, work in the other areas, and then work towards the break. So the membrane dissection around the break is to be taken care of towards the end of the surgery. And once we have a break and fibrous tissue is still attached, then we have to move on to a bimanual dissection. A unimanual dissection will again increase the risk of the retina becoming bullous. If the break happens in the later part of the surgery, once again switch to a bimanual dissection, because unimanual dissection, even in the later part of the surgery, with the retina being mobile, now that we have removed all the fibrous tissue, there's a high risk of the break extending uncontrollably. So I would usually switch to a bimanual dissection. And if fibrovascular proliferation is free of all attachments and mobile bullous retina, and if that tissue is not possible to dissect any further, then we may resort to a focal retinectomy as well. To summarize the management of diabetic tractional detachment, the more fundus details one can see, more difficult the surgery. Dissecting beneath the second membrane lessens the chance of bleeding and less risk of breaks. And using appropriate instruments like a needle to incise the posterior hyaloid, scissors and forceps wherever we need to sharp dissect the fibroscular nails, and a cutter for foldback dissection. And mid-peripheral, particularly inferonasal proliferations, are difficult, and those are the areas which are prone to breaks, and those are the areas where the hyaloid is strongly attached as well. And if a break happens, then we start dissecting elsewhere and work towards the break, and can use adjuncts in particularly adherent proliferations. Thank you very much for your kind attention.
Thank you, sir. As always, that was a masterclass, in the limited time that was there, and an overview in how to manage, all kinds of complex tractional retinal detachments in diabetics. Thank you, sir, for those multiple pearls on different cases. And before we head on over to, all our cases by our, discussants, I'll have just a few pointed questions to our vice counsel. We have Dr. Ramandeep, Dr. Subhendu Boral, sir, and Dr. Malika Goyal, madam. So if anyone, can, take this question. So any, apart from, the things that Mahesh sir so elegantly described in his talk, any particular, clues or anything different that one would do in young diabetics. So let's say people who are type 1 diabetics, who've had this, since they were 20s, 30s, and you're operating them when they are in their 20s and 30s. So anything different or uh, apart from the ordinary that one would do in those? Dr. Subhendu, Dr. Malika, Dr. Raman, anybody from the Vice Council, who would like to take that?
Yes, may I?
Most, yeah.
Basically, generally the young diabetes they are very much aggressive in nature, like diabetic proliferative vessels there. So you should be prepared. They may present as as straight away as a TRD or combined RD without any evidence of vitreous hemorrhage. Patient the vision may not be bad enough, maybe 618 or 612, but there is macula threatening TRD. So you have to be very much cautious. And for me, I will always do preparing like doing from outside in manner for the vitreous additions. You have to remove all the vitreous from the tractional, and whatever Sir has already shown that fibrous membrane, this kind of fibrous membrane is not generally happening in young diabetes. All are really vascular. So preoperative anti-VEGF within 3 days, and you have to operate within 3 to 4 days, maximum 5 days, because 7 days the TRD will be aggravated. By 21 days, it will lead to combined retinal detachment. Start giving this thing. So we insert the patient should be turned up for the surgery within 3 to 5 days. So for this was to eliminate the vascular components as much as possible and do whatever Sir was telling, that just utilizing all kind of, there is no hard and fixed rule that you have to go for this, like this kind of segmentation delimitation, or this kind of like lift and cut or the fold back technology, all this kind of delimitation technique, segmentation technique, delimitation technique. But still you should utilize all your experience to save and not to aggravate the TRD or lead to the combined RD, try to avoid break formation. Sometimes they may present as a lot of sclerosed vessel. All our discrimination is absolutely ischemic. Patient is less than 40 and highly uncontrolled diabetes, so associated nephropathy. So this kind of situation are very much risky, and chance of discolor in postoperative period is very high. Chance of neovascular glaucoma is very high. Try to do laser as much close to the ora serrata as possible. And at the end of surgery, I think I will always prefer giving anti-VEGF before giving silicone oil or gas. Thank you.
Yeah, probably we can add anterior retinal cryotherapy also to reduce the ischemia in these patients. But despite the aggressive nature, I find that the visual results and even anatomic results are actually better in the young diabetics compared to the ones who are in 50s and 60s in their age. So the results are somewhat better, and some maybe because the tissues are more healthy, but the results are better.
I'd just like to quickly ask a question to Raman sir. Actually, this was posted in the Q&A, so I'll take this opportunity to ask you, sir, before we go to our 3 lovely cases. So this is regarding the age-old question and debate about ILM peel in diabetic TRD, sir. So it's a twofold question, sir. Would you peel the ILM in all your diabetic TRDs, Raman sir? 1. And 2, if there is no macular hole, because this is what was asked in the Q&A by one of our attendees, and you get a hole in the posterior in the macula during dissection, then would you peel the ILM at that time? So Raman sir, what would be your take on that?
So, thanks, Mohit, for this question. Actually, can you hear me? So
can we increase the volume a little bit, sir? I'm sorry, it's just a little bit down.
We had this question in our mind. So when I think Rohan and I heard Rohan doing a Delhi team doing a lot of ILM peelings. So we did IOCT based study to whether to in one group we didn't peel the ILM, and other group we used MIOCT, and the result said that peeling is better in these patients. So you can peel in diabetic eyes. Visual gain was somehow equal in at 3 months. So where do I peel is whenever I see some kind of ILM fold there, these are the eyes which are, chronic looking, the TRDs. I would definitely peel in these eyes. And as you said that if I have a break there in the, the posterior, the macula area, I would prefer peel, but not laser these eyes. Yeah.
Thank you, sir. I think so. I think that answers the question fairly well, and we'll come back to this. We'll circle around these issues and come back. I can see Shanmugam sir's hand up. Sir, please, one last comment and then we go forward.
Just about the younger diabetics. Yeah, sometimes the younger diabetics can be difficult. So these are the patients where, like Dr. Malika mentioned or Dr. Kubaid mentioned, the extensive laser, as much laser as possible should be done. In addition, these are the patients where we may have to use an insert latch because the fibrous tissue may be extending very anteriorly. We may not be able to dissect very anteriorly. So this is one of the rare situations where we may have to use an insert latch because we are not able to dissect the fibrous tissue or the thickened hyaloid beyond the point.
Absolutely, so point well made. We'll come back to this. I think towards.
May I add something?
So can we come back after one question, after one presentation?
Just to avoid the incidence of anterior segment ischemia. For me, anterior segment ischemia in young diabetic is very high. So if you apply the anterior this insert clutch, that can aggravate the chance of anterior segment ischemia. That is another issue. Okay.
The point well taken. With that, we're going to dive straight into the second part of this, which are our three lovely cases. And they will help bring out certain subtle nuances of TRD surgeries. And without further ado, I invite Dr. Aditi Murthy, who's going to be speaking to us on tackling peg-like focal attachments in fibrovascular proliferations. Dr. Rohan Chawla will be the main discussant for this. Dr. Aditi, please.
Yes, sir. I'm just sharing my screen.
Please.
Are you able to see it, sir?
Yes, we can, madam.
Yes.
Okay. Good evening, everyone. I'm Dr. Aditi, and I'm going to present a video on tackling the peg-like focal attachments in fibrovascular proliferations. Our patient is a 48-year-old male. He's a known case of type 2 diabetes since 8 years. The best-corrected visual acuity in right eye is 6/9 and in the left eye is 3/60. Patient had PDR in both eyes and had undergone 3 sessions of PRP. In the left eye, patient had thick taut posterior hyaloid, causing distortion of the macula. Hence, was planned for left eye pars plana vitrectomy. Starting with the surgical video, 3 pars plana vitrectomy ports were made. Anterior vitrectomy was done. We are going ahead with an outside-in dissection. So temporally and inferiorly, we were able to find the plane of the posterior hyaloid. However, nasally, we were not able to find the plane. So we are going ahead with a irrigating macular lens, and we are trying to lift the fibrovascular proliferation from the disc. But as we can see, it is tightly adherent at the disc. So we decide to go ahead with the temporal dissection. So temporally, we had found the plane of PVD. So we are going ahead with the cutter and trimming the edges of the fibrovascular proliferation temporally with an outside-in approach. Gentle suction is used to gently lift off the fibrovascular sheet from the retina. Any bleed encountered must be diathermized immediately to keep the field clear. Using the ILM forceps, we are gently peeling off the fibrovascular sheet from the retina. And as we are peeling, we can see even the retina is being pulled along with the fibrovascular sheet at certain points because of peg-like focal attachments to the fibrovascular sheet. So it is important to first release these peg-like focal attachments. So we are doing that with the scissors, gently lifting the fibrovascular proliferation and cutting the focal attachments. Here also, as we are dissecting, we can see that there's some amount of traction temporally also. So it is important to release the traction temporally before going ahead with further posterior dissection. So going ahead with the similar dissection, we have created a plane temporally, and nasally also we have created a similar plane. And now we are able to cut the we are able to trim the fibrovascular proliferation 360 degree, such that we are left with only with a thick sheet at the posterior pole, which is attached at the disc and the macula. So for this part, we again switch to an irrigating lens. And here we can see it is very tightly adherent at the disc and the macula, and we are not able to find a plane. So in such cases, it is first important to clear the field and have a good view. So we are going ahead with an extrusion to disperse the bleed so that we can have a clear view of the planes. So for this last bit of dissection at the macula, the scissors provides a more controlled dissection. Once that is released, we are able to peel it off from the disc and the macula. And finally, only a small sheet of fibrovascular tissue is left at the superotemporal arcade. So we are trimming it with the cutter. And since the last bit is very tightly adhered to the retina, we are just trimming it 360 degrees and diathermizing any small bleeders, and we are leaving that small sheet as it is. Now we are proceeding with the peripheral vitrectomy. And completing the PRP at the posterior pole. The peripheral PRP was already complete. And closing the case after the fluid air exchange. We've closed the case under air. Thank you.
Aditi, can you just have the video on again, and I can maybe give some comments along with that? Is that
Absolutely,
Yes.
Dr. Rohan, I was about to come to you, sir. Yeah. Great video and presentation, Dr. Aditi, by the way.
Thank you, sir.
Okay. So just
Dr.
started
Rohan.
from the beginning.
Yes.
So like Dr. Aditi said, we first tried to find the plane of the posterior hyaloid, and I was able to do this temporally, but not able to do this nasally. So, but still, whatever amount you can do, you cut it so that you can reach the fibrovascular proliferation in that aspect of the retina at least. And then some of the cases I try to do a mini PVD at the disc. That is what I was trying. Just slightly forwarded. Yeah, so sometimes you can get a small PVD over here, and you can get a gap there where you can insinuate the cutter, but in this case, since the adherence was strong, probably I was unable to do it. So then I shifted back from rather going inside out to outside in again, and then from temporally where I had the edge, I started cutting the membranes and superiorly and bringing them inwards. But wherever you lift it gently and you find those peg like attachments, which sir has already mentioned, so there you switch your instrument, and I like the curved scissors. So I insinuate the curved scissors and then cut these small pegs. This is what I wanted to demonstrate. And with the scissors, you can use it as a sharp dissection as well as you can use it as a blunt dissection. Sometimes I just use it like a forceps to lift the membrane as well. And here you see I'm cutting the peg, but I feel the extension is going much beyond nasally. So then first you have to go and tackle the nasal extension so that the traction over there is relieved. Otherwise, if you keep dissecting at the posterior pole, you're going to get a break right here in the supranasal area. So if the traction goes peripheral, that second membrane, so you handle that and then you come back to the center. So these are some slow things which you can learn along the way, which can help you prevent small things, which help you prevent breaks and bleeders. And then like we had seen in the OCT itself, the membrane was not attached totally. There were some gaps. So those are the gaps which we are taking benefit of during the surgery, and we are trying to peel off, delaminate the entire membrane, and then a small part of it is left at the superior arcade, which I just left. And here the macula does not appear very healthy, so I have not done actually ILM peeling in this case. And actually what she showed inferiorly while we were lifting up the PVD, there was a small break, but fortunately no fluid, nothing. So we just lasered that break below the inferior arcade, and I closed the case under gas itself. These are just some points from my side. Thank you.
Well, thank you again, Rohan, for great, great surgery and great points to be brought out. Dr. Aditi, can you stop sharing so that we can have a, view of all the discussants? Malika ma'am, your take and your points, on this.
Well, this was too good. I do not have much to add by and large, the surgery would be similar if I were to do. I think to avoid diathermy close to the disc or on the disc, I've had an experience of PL negative by touching the disc with diathermy. I'm not sure whether that was a causal relationship or not, but we have to be careful with that. And diathermizing is good, but it can create breaks. That also we have to understand. So the diathermy should be a little superficial and not with great force to avoid creating breaks. That's what I would say.
Dr. Boral, we can have one comment or anything or addition or detraction from you on that, and then we can go to the other case.
I have 3 points to highlight. Like, it's a great video and without causing much breaks. But thing is, the most of the retina was very much ischemic, and there was outside in manner the attached membrane was lifting up. So in those cases, the chance of break formation was quite high. So rather, I will reinforce from inside out cut whenever the membrane is at the posterior pole, it's very thickly adhered. Number two, bimanual surgery could have been a better choice rather than doing this oblique scissor, although the surgery has done nicely. Number three, viscodissection. This is like age-old technique, long back, but I will prefer this viscodissection technique to separate the membrane from the underlying, almost like very thickly adhered membrane for this kind of situation with 27 gauge curved needle, visco cannula needle. I can do this viscodissection.
Thank you, sir. Can I request Dr. Ashwini Kumar Singh to try and start to share his presentation? And I just want to make two small comments till the time that's happening. There are two questions/opinions in the quick Q&A about the use of rollback delamination that could have been done at certain point in time in the surgery. I agree. I think it could have been done. I think Mahesh showed in, if I'm not mistaken, in I think the second of his cases, that being done elegantly. So yes, rollback delamination there after a part of that membrane was cleared could have been done. With that, we come to Dr. Ashwini and Dr. Alok Sen sir is going to be the discussant. So Dr. Ashwini, please.
So my screen is visible?
Absolutely, and you're audible as well.
Yeah. So good evening. I'll be presenting a case of a diabetic tractional retinal detachment. So the case was a 47-year-old female who presented to us for diminution of vision in the left eye since 15 days and who was a known case of diabetes since 5 years. The vision in the left eye was hand movements and the anterior segment was within normal limits. At the posterior segment, we could only visualize vitreous hemorrhage and a fibrovascular proliferation at the disc itself. So we went ahead with the B scan, which showed medium to high reflective mobile vitreous echoes, which is suggestive of vitreous hemorrhage with a dense fibrovascular proliferative membrane attached to the posterior retina, which is causing tractional changes. So we went ahead and planned this patient for a diabetic vitrectomy with Ficoil anti-VEGF and a diabetic vitrectomy. So we started the case with a standard 3-pass plane approach with Chandler superiorly. The initial view was obscured by dense media opacities, so an anterior vitrectomy was done, followed by a core vitrectomy to clear out the central vitreous cavity. So once the core was cleared, we could visualize a thick and elevated and highly vascularized membrane, which was adherent to the underlying retina. So the vitreous cutter was used to trim the bridging anterior posterior tractional bands, and we separated out the membranes from the anterior connections. Further, we tried to induce a partial PVD, which was used to create a plane, and we used it to do the further dissection. So after this, we started the dissection of the fibrovascular membrane. We continued on with the dissection of the membrane. As we continued on the dissection of the membrane, we were able to identify a secondary membrane. It is important to identify a secondary membrane because it will help us identify a proper plane for further dissection. After removal of the secondary membrane, we used the cutter to divide the fibrovascular plaques into smaller isolated islands or segments, known as segmentation, and this immediately relieved the broad tangential traction which was pulling across the macular region. Further, the cutter was used in a horizontal plane to carefully shade off these islands from the underlying retina, and it was used to break the peg-like attachments to the retinal vessels. As we continued with the delamination, we were able to identify another secondary membrane, and we will be dissecting it out as visible here. Further, after removal of the membrane, using the fold-back technique, where we are placing the mouth of the detector directly atop the isolated tissue, will allow the free-floating edges of the segmented membrane to naturally enter the cutter and to be shaved away from the top to downward, as visible here. Post this, we continued with the segmentation and delamination superior temporally. At the periphery, we were able to see there's a presence of posterior cortical vitreous, and there was a and there was broad traction. So we tried to remove the broad traction. Since the retina was very mobile, we shifted to a biomanual dissection using micro forceps and micro scissors under the guidance of the chandelier. We further continued on with the biomanual dissection, and we removed the peripheral traction further. Post the removal of the peripheral traction, we stained the ileum using BVG and proceeded further with peeling of the ileum using the ileum forceps at the macula itself. And post peeling, we further injected the PFCL, and it was injected at the posterior pole. And with the PFCL guidance, we did the base dissection in all the quadrants. Once the base dissection was done, the PFCL was aspirated out and the fluid air exchange was done. Post FACS, we did an extensive laser at the posterior pole and the periphery, and the case was closed at the siliconal temple. Thank you.
Thank you, Ashwini. Am
Thank
I
you,
audible?
Dr. Ashwini, great case. Alok Sen, sir, please.
Yeah. So, Ashwini, I think we have been discussing diabetics in the start of the webinar, and all the points that MPS sir had already highlighted, and most of it happened in this case. So the case we selected because it had everything in it: bimanual dissection, the retina getting detached, removing the hyaloid, all the things. So, Ashwini, can you go through the video once again and just slide and move to and what Dr. Rohan was talking about mini PVD. That is what was demonstrated in this case as well, where we had this broad membrane which was firmly adherent to the macula. So just creating a mini PVD helps in getting the plane and helps in dissecting. The other thing that was also evident in this case, which MPS sirs very elegantly pointed out, was that once you are going through and you are unable to insinuate your cutter under the membrane, that means there is a second membrane. So in this, Ashwini, so here was the point where I was unable to insinuate. So I went and searched for the second membrane, and you can see the membrane coming out from the other side. And once that membrane, we could identify the membrane, the second plane, and then it becomes very easy to then insinuate your cutter and segment the membrane. So that's the second thing that uh, MPS sir had already pointed out, which I wanted to highlight through the case. And of course, the inferior part was always very difficult. It was very adherent, and hence it was dealt at the end of at the last, so that even if I get a retinal detachment, I know that I have removed the superior majority of the membrane. So once you know that the retina is very mobile, you have to shift to bimanual, and then you slowly lift, and as Dr. Rohan also pointed out, you find these pegs, you cut, and you keep lifting and using the scissors as both for cutting the pegs as well as for blunt dissection. And you can deal with most of the membrane, as you can see. The PFCL that was used was to stabilize the peripheral, stabilize the retina, which was mobile, so as to remove the peripheral, complete the base dissection. Otherwise, you can land up in a lot of breaks while doing the base dissection in this case. I think, and at the end, the most important, probably what I've learned from my gurus, is to do a very good lasers in this case, because that's what is mandatory to do a very thorough 360-degree laser up to the aura. That is what we usually do in these cases. Thank you, Mohit. I think we can have more discussion on this.
Thank you, sir. Thank you for those great points. Raman, sir, I'm going to just dive straight into it, and I have two pointed questions for you, sir. So one would be regarding leaving behind some membranes, sir. So when would you? So would you consider leaving behind some membranes? If it's no, then absolutely fine. But if it's yes, what scenarios? And what scenarios would you definitely not leave? That is one. And two, both the cases we saw very challenging, very complex. We didn't see the use of. We've talked about second membranes quite a bit, but we didn't see the use of Canacort or triamcinolone triamcinolone at any point in time during any of those surgeries. So what would be your take on this? We keep talking about vitreoscheisis in diabetics all the time. Use of triamcinolone, when, where, TRDs, and your choice and your opinion on leaving membranes behind, when and when not, sir.
So I'll answer the second question first. I mean, we use a triamcinolone a lot here, actually. We always believe that if you have not put triamcinolone, you have not found the true plane. So we use a lot of triamcinolone here, and we tend to find the sciatic layer with the triamcinolone. But you're right. Sometimes you find a secondary membrane, the layer is not there. You are not able to the hyaloid is gone. But there's no harm in putting triamcinolone and at least clearing your the posterior pole of the of the hyaloid, because in the periphery, the most of the time the laser has been done, and you don't have to change that. So I use triamcinolone a lot to identify the remnant hyaloid, and in sometimes the secondary membrane can be found. So to answer the second question, I don't leave any membranes behind. I don't even leave the nodes there, actually. A node is like it's a inverted saucer kind of a thing. If it's like a saucer, it's like then I can leave that node. Otherwise, I don't leave it. In this case, I particularly saw that there was a TRD going up to the periphery there. They had, because they have done the cataract surgery also in this. I have seen that the cataract wound was irrigated, and simultaneous cataract surgery was done. Had this eye been in a phakic, and if I would have found on the ultrasound that this TRD was going up to the aura, I would have preferred a buccal there and would have left the membrane in the periphery. But otherwise, I will chase the membrane most of the time. But there are areas like upper nasal areas. Sometimes you are not going to chase these membranes. But luckily, in diabetics, we don't see such traction. Such traction, the peripheral tractions are more common in the vasculatic part. So vasculatic, but luckily they are not that extensive. But yes, in the post-equatorial area, I will not leave any membrane there. But if it is area beyond that, and if it is too much, I would like to put a cephalad bucket. Sorry for the long answer.
Fair enough, sir. Points well taken. I think that's why, I just thought of that once for going to the periphery, that I must ask that question, that whether there's a school of thought that you can leave, because there is some evidence coming from Japan regarding the same also. Malika, madam, a question to you before we jump on to Dr. Abhijat's case. When would you not operate, madam? You see a TRD or you see a bad diabetic CRD, because I think that was something I wanted to ask towards the last part of this, but it came up in the Q&A. So what would be your pointers when you would say that, enough's enough, no surgery?
Okay, when the retina looks extremely ischemic, the vision is disproportionately poor, patient has a good eye, other eye is reasonably good. So when the visual prognosis looks poor, when the TRD is not much, macula is not too elevated, but the vision is extremely poor. So we can understand most of the time that it's the ischemia which is causing the problem. I think that's, but if it's a one-eyed patient, then probably you would do whatever you can, provided you're sure you're not going to make them worse than what they are. There's also some cases where you very high chance that the things may actually get worse because of surgery. Very high chance. So there, if it's a one-eyed patient, probably you would leave them alone. But if there is a reasonable chance and very poor prognosis, you'd probably, if there's a reasonable chance, go ahead. If it's a one-eyed patient, if the other eye is good and this eye seems ischemic, very ischemic, I think that's the biggest point I would say, or new vessels on the iris, maybe. But again, if new vessels on the iris in a one-eyed patient, you could inject an anti-VEGF and still proceed. Coming to that video which we just saw, the PFCL helps also to do a good laser over most of the retina, at least up to the equator, before we do a fluid air exchange. So PFCL can be left in situ to be able to do a good laser, and then fluid air exchange can start. In fact, in many cases where we are not able to achieve a good laser over the retina, because of some elevation, we can just put PFCL, which flattens out the retina to allow a very good satisfactory laser over most of the retina, not the periphery maybe. And then we remove the PFCL, of course, but this is only to allow very good laser in cases where you're not able to achieve good laser.
One last point from you. So Bhendu sir, just building on what I asked Dr. Malika, when would you say, or when would you counsel against surgery? When would you not be operating?
Like when the other eye has been operated by me, and that unfortunately the eye has gone to the neovascular glaucoma state. So in the other eye, the seeing eye is having 624 or 618 vision, but there is multiple TRD not involved in the macula. So I will prefer not to operate because like it may follow the same course, just like the other eye. So in those situations, and Dr. Mallika has already highlighted that the patient has a submission, but a lot of global ischemia kind of situation. In those two situations, like poor vision and very good vision, patient is one-eyed. In those situations, I am not going to operate.
Fair enough, madam. Fair enough. So thank you. With that, we come and we dive to the third case. Dr. Abhijat Chaturvedi, if you can start sharing, and Dr. Devakant Mishra is going to be the discussant. We have a few questions, which we will be tackling at the end of this. Mahesh sir, there's a question directed to you in the question box. If you can just answer, sir. Dhananjay Shukla sir wants to know the inflection point. Dr. Abhijat, please.
Sure. Thank you at the outset. I would like to thank VRSI for giving me this wonderful opportunity. Firstly, I would like to start my presentation by saying that though I'm a practicing surgeon, but it's never too late to learn. Hence, I joined Dr. Devakant sir as a trainee vitreoretinal surgeon. And I wanted always to learn how to tackle such bad cases of TRD. And I'm just going to demonstrate you all that by just using one single instrument, also bad TRDs can be tackled. But you just definitely need to know the technique. So when we begin this case, this is a gentleman who's 54 years old and a bad metabolic status. You can see that there's a very bad TRD involving the disc and macula, and even it's extending till the nasal side. So again, as told by our seniors, we prefer the outside-in approach, and we try to find a plane of dissection. So the dictum that I follow over here is that you just nudge your cutter or insinuate the cutter below the membrane, slightly elevate the membrane, and once you find that plane, you start your dissection and you start your delamination. So this patient was injected with an anti-VEGF also 3 days prior to the surgery, just to avoid very bad bleeds. So, but despite that, you will see in this case also that as we go on ahead with the dissection, there are some bleeders. So very careful cauterization is done. And as pointed out by MPS sir very beautifully and elegantly, that yes, cautery should be avoided in major cases.
Dr. Abhijat, I'm sorry, I'm interrupting.
You can just cauterize the tip of the vessel.
Dr. Abhijat,
And that should stop
there's an issue with your video, I think.
Now, once all this is completed, then I start with the circumferential approach. And once the circumferential approach is taken,
Mr. Sai should take care of this.
the traction
Sai can
starts to
take
get
care.
Dr.
relieved
Vijay,
on the
Dr. Vijay,
macular
sorry,
area, and finally the
interjecting.
membrane is
Hello.
removed from the disc. But again, as you see, our
Devkan,
job
यदि
doesn't
कॉल
stop
tell
here.
him to stop.
So
The
There is a
Sai
now
problem
can
we
with
stop
his
need to
it.
network.
remove
Sai
the
can stop
traction
I
it.
think
from the
the
inferior
problem with
half
his
of the
network, because
retina
even
as
his
well.
video is not
Again,
working.
following the same
So I don't
dictum,
think Sai
Dr.
can take
Abhijat,
care of
can you
that.
hear us?
nudge your vitrector below the membrane, try to elevate it slightly,
Can I
and then
stop,
go
doctor?
ahead with your
I'll just
dissection. The dissection should be
Mr.
very
Sai can do
careful
it.
and
Sai
a
can do
very
it.
Can I
patient
stop?
dissection. Your mind
Yeah,
should
yeah,
act
yeah.
like a monk. Never ever hurry. And there's a temptation to, just lift up the membrane whenever you see the membrane. So
You can stop his video, yeah.
Dr. Abhijat, we were trying to tell you that your video is not working. Can you hear us now?
yeah. Now I can hear you.
Video was not playing, it was stuck.
It got stuck.
Okay.
Yeah, and I just kept quiet till Divakant messaged me because I was
Can
like,
you tell
it
me
might
where
be an
it
issue
was
with just
stuck?
me. So apologies, I should have done this earlier. But
Abhijat,
we just couldn't see anything apart from the first 5 seconds of the video.
Okay.
maybe you can switch off your video so that probably there's some connectivity issue at your end.
So is it displaying now?
You will have to restart the video.
Is the video displaying now?
Yeah,
it's playing now, but it's still.
I feel it's still not. It's better than before.
Video is somehow not coming.
What I'll do, Abhijat, I'll play from my end and maybe you can narrate from there. Yeah. I'll just try to share.
Yeah.
Yeah. Is it visible now?
Yeah.
Yeah. Abhijat, I'll just play and.
Perfect. So I'll again start with the beginning only. So once this vitrectomy part is taken care of, we carefully start our dissection using the outside-in approach. And as I said before, also the dictum that we are used to following here, and that I learned from Divakant sir, is that you try to find a plane. You slightly nudge the vitrector below the membrane, slightly elevate it, and once you're confident that you have achieved a plane, you can go ahead with your cutter. Now, these membranes, you can see that they have very notorious bleeders once you remove these membranes. Hence, this patient was injected with an anti-VEGF 3 days prior to the surgery. But even despite that, the active FVPs, though they went silent, but still you can find that there will be bleeders. Like you just after removal, you can see that there's a bleeder. So MPS are told very correctly that cauterization should be avoided, as it might lead you to creating iatrogenic breaks. But yes, these careful cauteries can be carried out, where you just cauterize the tip of the vessel and you try to stop the bleed. However, if the bleeder is not very significant, you can also leave it till the end of the case. Now, once that traction is relieved slightly to the superior half of the macula, now next we choose the approach to go for a circumferential dissection around the disc. Now you can see that this dissection is being carried out so that we can separate out the membrane that is present in the inferior half from the superior ones, and this slightly relaxes the retina a little bit. Once this dissection is completed over the disc, then we will move ahead to the next part of the dissection. Now, coming on to the inferior part, you can see that the retina is very fragile over here. It's quite ischemic as well. So you need to have patience. The patience is the key. The mind of a monk is required here, because there's a temptation, to peel off this membrane. And once you try to peel off this very adherent membrane, you might land up with iatrogenic breaks, and very well with a combined retinal detachment. And that might, you might have to close your case there. So whenever that temptation creeps in, always remember, just stay calm and follow your dictum, and you will be able to perform the surgery very well. Now you can see that again in this membrane also, we are trying to do the dissection using a single instrument only and following the same dictum. Just nudge, elevate, and then slightly eat up the membrane. It's not required always to completely remove each and every membrane, but if you can, then very well. The main goal should be that the traction should be relieved. If the traction remains, then the goal of the surgery would become null and void. Now, once that area is complete, we need to clear the macular area. So in order to clear the macular area, again, the area beyond the arcade needs to be dissected and separated first. Now, there was a bleeder here also, but lucky for us, it didn't bleed a lot. And then again, we started doing the dissection. Once this delamination is being carried out, you can see that again, we land up with a very notorious bleeder. This is the bleeder that I would personally not want to cauterize because it's very near to the foveal area also. It's in the macula. And since you can see that the retina is quite atrophic here, I very well may create an iatrogenic break here. So again, these can very easily be managed with this single instrument. But yes, you need to know the technique. And if once you know the technique and you have patience, you can just move ahead with the surgery also. One very important thing in handling such cases is that you need a bimanual dexterity as well. Many a times the membranes which are present in the nasal half of the retina, that would need the usage of your non-dominant hand. So in this case, it's the left hand. So a gross dissection of the membranes can be carried out with using your non-dominant hand. And that's why all the vitreoretinal surgeons should be ambidextrous, and they are generally, which is a boon for all of us. Now, once this gross dissection is carried out, the finer dissection and the part that needs to be finished up can be done using a dominant hand again. Now, you can clearly see that majority of the membranes have been removed. A lot of retina has settled down, but still your job is not complete as there's a huge amount of membrane still remaining in the superior half of the retina, and that also needs to be tackled now. So again, in a similar fashion, and taking care of not hurting the vessels also and not hurting the atrophic or the ischemic retina also, a similar dissection has been carried out. And the blood clot that you can see that is over the disc, this is also removed very carefully. And finally, once the retina settles down, the close is cased using fluid-air exchange, and the tamponade is given in the form of air. Thank you so much.
All right.
Thank you, Dr. Abhijat. Murid, please.
No, nothing. Please, Mohit, go ahead. Just a very nice case, Dr. Abhijat. Just, I actually had a question. I think you already had discussed. I was able to catch up the last part, but this is pertaining to this video as well as to a lot of other videos. What, according to all of our panel, all of our vice counsel, Dr. MPS, or everyone, is their thought process on a limited vitrectomy? I mean, there are times, there have been videos which have come, there have been discussions where you can probably leave behind some of the tractional peripheral membranes in the periphery, with the caveat that you avoid creating a peripheral break or create an iatrogenic break. So what is your threshold of a trade-off? Where will you think you can probably just free up the foveal area, free up the macula, and if there are some peripheral traction, you must just observe it. So this is something which keeps on coming in the mind of beginners as well as in everybody else's mind. So what are your thoughts? Maybe I'll start with Dr. MPS sir, then Dr. Malika ma'am, and then the entire vice council and all of our discussants.
If you're able to induce the peripheral highlight separation, and we can leave behind these islands of fibrous tissue, particularly on the nasal side, or away from the arcade, if you're not exerting traction on the macula. For beginners, you can't do that. Provided, as I mentioned, if you're able to truncate the anterior hyaloid from the fibrous tissue towards the vitreous space. There have been situations earlier when we didn't have a wide angle system where I have just cleared the macula and left the whole fibrous tissue from the arcade to the periphery. It was like probably 20, 30 years back in 1 or 2 cases where I knew that like if I try doing that, there can be breaks. And fortunately, in that particular patient, the PVD occurred and it happened by itself. Otherwise, like the key is not to create a break. If you created a break, then all the dissection has to be done. If you create a break and then leave the fibrous tissue and think that oil is going to take care, that's not going to work. The patient is going to come back with oil under the subretinal space. So I'm not like, of course, it's always very inviting to remove all the fibrous tissue, and whoever has spoken are all experienced surgeons. We all show that like removing all the fibrous tissue. But it's okay to leave the fibrous tissue if it is not exerting traction on the macula, provided we isolate it as islands and leave it alone. But I wouldn't be comfortable doing just a limited vitrectomy, clear the macula and come. As I mentioned, extremely rarely I have done that. But now with the adjuncts available, as I mentioned, if I find a patient like that, now I would inject autologous plasmin and anti-VEGF, and that will loosen up the hyaloid enough for me to remove the hyaloid, remove the fibrous tissue in most of the patients.
Rohan sir has a point to make.
Yeah, here just I wanted to ask, sir, like you again mentioned plasmin. You have been operating so many years, and sir, you're the master of surgery. So before plasmin era and after plasmin era, do you really feel it has made a difference? And how many days before do you inject? Because we all of us use anti-VEGF, but I think very few of us use plasmin autologous.
That's like it's a very difficult question to answer, but I do tend to believe that it works. Like not all the patients, but like where we find that the hyaloid is completely plastered from the disc to the periphery, and most of these are young patients with one eye already being lost. In those patients, I give everything possible. Plasmin, in the sense, what I do is to inject 0.1 ml of like about 25 to 30 micrograms of the TPA and autologous blood, 0.1 ml of autologous blood and anti-VEGF. All these three are injected about 2 days prior to the surgery. So that's what I do. It's not on the same day, but it's 2 days prior to the surgery. I tend to believe that it helps. But as I mentioned, in these patients, we don't want to take a chance. So I give everything possible to achieve success in these eyes. That's the reason I inject autologous plasmin in select patients.
Thank you, sir. Thank you.
All right.
Dr. Mallika, ma'am was saying
Yeah.
something.
As Dr. Shanmugam said, all these points, but sometimes when your proliferation is peripheral, mid-peripheral, and you feel that removing, there is a very high risk of creating breaks because the retina is very thin and ischemic. So I would take the luxury of probably leaving it, and the patient should have been counseled beforehand, especially in diabetic cases, that there might be second surgery required because we may play safe in the first surgery. And so we can take the chance of leaving tissue inside if we feel that by pushing the issue, we may create more problems. And then if the post-operatively we find that the traction has progressed or there was a break which was missed, then you can always go back in because the patient is already aware that it might require a second surgery.
One option is to actually support this peripheral fibrous tissue proliferation with a buckle. So there are situations where I put a solid silicon and a denser clutch in the particularly inferior nasally where we are not able to dissect. You can put a solid silicon and support the peripheral fibrous tissue which is extending up to the vora serrata with the silicon buckle as well.
Wait, I'll come to Dr. Subhendu Boral with a question and just add a point here. So if in vasculitic TRDs and RVO TRDs, I think if one has separated it from the attachment to the disc, the macula is free, and it has been truncated down, the vitreous attached to it, you'll be surprised as to how well they'll just stay there. And this is without tamponade and without a lot of things. And if it's circumferential, if it's a larger element that one wants to leave, then absolutely, as Mahesh sir said, I think encirclage with the broader tire makes sense. But otherwise, just leaving that wedge or like that a clock hour and a half, does just fine. Subhendu sir, I'm going to come to you. Tips regarding bimanual dissection. When would you want to switch to it? Do you decide beforehand? Do you decide intra-op? Your choice of instruments, and where would you want to insert the chandelier? Is it 6? Is it 12? Is it variable? How would you go about that?
Like not at a 6 o'clock. It is the other fourth quadrant, whatever it is, infranasal quadrant. That is good enough for me because this quadrant it will give the almost some papers at the 6 o'clock, but I will always prefer infranasal part. And the second thing is the bimanual surgery. It is sometimes it's very much evident that a lot of TRD, combined TRD membranes are there and they are elevated with the broad-based additions. So in those situations, bimanual surgeries will be really helpful. Multiple TRD, like focal attachment, you may or may not. You thought that it is very much like can be manageable with the cutter only. But on table, you have to change you have to be very flexible in your treatment management situation. During the surgery, you have to decide whether you can shift to the bimanual, you can put the sinuous light and carry on the rest of the part.
Raman sir, regarding your choice of pre-operative anti-VEGF at the end of surgery, both case-based, economics-based, what is your take on this, sir? Anti-VEGF pre, intra, both, none?
Okay. You're talking about TRDs.
TRDs and CRDs, sir. Tractional and combined detachment, sir.
If there are no financial issues, I want before also and end of the surgery also. I want end of the surgery also. And
But real life, sir, if you're pushed against the wall and just one bite at the cherry, which typically is what we get, then what would be your
in real life, it's case based. COVID has taught us that it works 1 day prior also in some cases. And most of the time we use 3 to 5 days, but COVID did taught us that you can use it 1 day prior also. And post-operatively, I want cases, where I am expecting, a lot of these, the NVG, because I've done a lot of laser there, and I have left a lot of area unlasered. So because I don't laser much. If you have where there's a break and a traction there, I even use this. I think I've used methotrexate also now post-operatively, and it works. I don't have the results, but I see equally both working very well. Yeah, post-operatively.
Mahesh, sir, you have your hand up, sir.
Yeah, regarding the bimanual surgery, I would suggest the beginners actually start with the bimanual surgery. So it's much more easier to handle these cases rather than try unimanual. Earlier we didn't have, so we did unimanual. But bimanual, it offers a lot of advantages because the breakless dissection and also hemostasis. For that matter, you can use a flute in one hand, take it close to the bleeder, and as the blood which is leaking from the bleeder is absorbed, then you can take the cautery and precisely you can do the cautery. So you can do that, and you can use scissors and forceps, forceps and cutter. So I would suggest that like all the youngsters who start with the bimanual surgery, put the fourth port, like it becomes difficult to put the fourth port in the middle of the surgery. So you may use it, you may not use it, but put the chandelier and then start off with the bimanual surgery. That will result in a lot of less heartburn.
And one more question, sir, since you're at it, where would you suggest, people starting out 6 or 12 regarding the range shadow? You can have the, that shadow of the instrument. So, how would you say which case to do what in?
I would usually look at where the most dense adhesion is and where I would probably dissect. So it should be the opposite side. So I usually place it somewhere just nasal to the 12 o'clock meridian. But then looking at the anatomy, so the most complex dissection area, opposite to that, if you placed it at the chandelier, that would be the best.
Absolutely. Raman, sir, you had your hand up, sir, regarding the...
Just a single point, sir was talking about, Dr. Mahesa said about beginners. I always tell my beginners to start in the lower quadrant, when they are fresh actually, because that's where I don't want breaks there. So you start there and, do the dissection in the lower quadrant first, and then move up, because upper break is a little more forgiving than the lower break. And of course, like Dr. Mahesh said, leave that break somewhere else, and do not try to drain to this ever beforehand, because this gel vitreous is more supportive to the retina than the liquid vitreous.
Madam, Malika, madam.
Yeah, I want to make a couple of points. One is that the advantage of leaving the silicone oil is not only the tamponade, even in patients where there is no RD, is to have a clear media post-operative, which, as Dr. Shanmugam said, is important in one-eyed patients for ambulation. But apart from that, it allows us the clear media to continue laser post-operative. Because, a lot of laser is required, and many of these had never had laser before surgery. So we need the clear media even to manage the case post-operatively. So my use of oil in these patients is very high, simply for these reasons, to allow management and patient ambulation. We also had a very interesting case a patient who has advanced nephropathy, which most of them have, they are on dialysis, etc. So they also have anemia because of this nephropathy. He was an erythropoietin for that, for the anemia, and that leads to very high RBC count. So his hemoglobin was on the higher side, say about 14 or 16. But the anesthetist didn't pick it up as a problem, and we had really solid blood sitting on the posterior pole, and we spent about 2 hours trying to remove that blood, but it was just stuck like leather to the posterior pole. So later we realized the problem and then brought him back for surgery later on. So this is an important thing to note, whether the patients are on erythropoietin, and they should be put off erythropoietin. It is a known agent which, in fact, it is used in orthopedics, etc., to not allow bleeding and to make the blood more solid by increasing the cellularity. I think that's, and also to touch upon the use of fibrin glue, which I started for these cases of PDR, where because of bleeding or edema or proximity to the macula, you're not able to close the breaks with laser. Very often we cannot laser because of the bleeding. Nowadays, because of anti-VEGF, probably bleeding is less, but it still happens. And there, in desperate cases, fibrin glue we started using, but now more routinely. And these breaks close very well. And then you can tamponade them with gas or oil. But it really works very well where you might otherwise lose the patient to close these breaks.
Good points, madam. If I can just ask you one counter question regarding the silicone oil and then go to Rohan Chawla, sir. So when you put in oil in some of these cases, and we totally understand that early ambulation, one-eyed patients, and that's a factor. What would be the time that you would want to get the oil out in eyes that it is not for a regma supporting kind of a indication? And is it predetermined, and how do you go about that?
Yeah, so I think that would, when all new vessels have regressed, your laser is complete, and you are quite sure that now if you remove the oil, the patient will not bleed. But if you're seeing NVD, NVE, then you don't remove it. You know it will bleed. So you complete the laser as much as you can, fill in, and then when there is no new vessels, then you remove the oil.
Fair enough, madam. Points well taken. I think also important for everyone to know that this is not like a rheumatogenius RD with PVR. That's a separate story, this separate story. Rohan Chawla, sir, your hand's been up for some time, sir.
Thank you. No, I just wanted to add about beginners, what sir has been saying. So initially for beginners, there is always a hesitation to start bimanual. But I think like sir said, you go ahead and do bimanual, because when you start holding it with two hands and holding the membranes, then you get a better understanding of the planes and the second membrane. And slowly, initially when I started bimanual, I did a lot of bimanuals, and now learning from that, my need for bimanual has reduced. So like in the case which I showed, where I was able to nudge with the cutter and I got the space, so I did not introduce a bimanual. Had I done this surgery maybe a few years back, I might have done it using a bimanual technique. So with the experience of bimanual, your unimanual improves.
I agree, sir. I think in general you become a better surgeon and you know what to do at what point in time. Totally agree. Just one last question to Alok Sen, sir. There are two questions posted in the Q&A, and after that I'll hand this over to Mudit. He told me the hard stop at 8:20, and hopefully we're not going to overshoot. Alok Sen, sir, there are two questions, and this is, I think, in general for diabetic vitrectomies, also would hold true for diabetic TRDs. So this is regarding vitreous-based, depressed vitreous-based dissection in all diabetics. Would you do it? Would you not? And this is not just for TRDs. So with heme, TPHM, let's say TRD, CRD, maybe you can cover all of these. And the other question is, again, the age-old dilemma about fibrosis and fibrovascular proliferations over the disc. Everybody wants to try and do the mini PVD, and that's convenient because the retina is thicker and all of that. But you could have potential bleeds there. And if you do, then what do you try and do if you get disc bleed while doing that? So just those two questions to be answered.
Yeah. Thank you, Mohit. Am I audible?
Absolutely, sir.
Yeah. So the first question was regarding the base dissection, whether you do it. So for me, whatever I have learned is that once you go in, you remove as much as vitreous possible, because vitreous is the culprit there. So I try to do it as much as possible in all my cases, including diabetic vitrectomy, unless until I am doing a young patient, or I have put a belt in some of these cases where you know that you can get away with some of the peripheral vectors. But in most of cases, I do try to remove as much as vectors as possible, along with anti-VEGFs. So that helps us with the phase dissection when we are doing. Regarding the second question, when we try to do a mini PVD, what we do is we not exactly lift it at the disc. We do it in the peripapillary area so that we can find a plane. In case there is a bleed, it is sometimes very difficult to control, especially if you are remove the what is the general teaching is that you remove the font at the disc at the end. If at all you want to remove, you can leave also. But if you have a bleed, then the only way is to increase the intraocular pressure, and hopefully that pressure helps you reduce the bleed. There would be some amount of clot there. You can leave that clot without dislodging it. So IOP can be raised and it can be gradually brought down. So you can raise it to 640 and 30 and see whether there is bleed. Told that if you cauterize over the disc, you might land up with optic atrophy. You can use probably fibrin glue there, which can help in doing the break. But what I generally do is I do a fax using air as a tamponade, raise the IOP and slowly then reduce the IOP so that the bleeding stops there.
Points well made, sir. Mudit, over to you.
All right, no, nothing. Thank you so much, Mohit. And thank you so much, everyone. Thanks, Dr. MPS, sir, Malika Goel, ma'am, Raman, sir, Subindu Bural, sir, Dr. Alok Sen, Devkan, Dr. Rohan, sir. Thank you so much, Aditi, Ashwini, and everybody else who shared their great cases and for such a wonderful discussion. I think all of us have learned a lot, and all of us have benefited from so many new points that we have come across. Hopefully, we will be able to translate a lot of this learning into our surgical cases, and that will also help us in our cases. So thank you so much once again, and a huge shout out also to the team from Neurotech for helping us with all the logistic support, and to everyone who has joined, to all of our participants who have joined us today. For those who could not join, all of these webinars are available on YouTube and on the VRSI website. So go to YouTube and you can go and have a look at them. Whenever you want to revise all of these points again, there are some really amazing learning points, and I'm sure all of us will benefit if we listen to them again. So thanks for joining us today evening, and on behalf of everyone in VRSI, once again, thanks a lot. Have a great day and a great evening.
Thank you, Dr.
Thank
Mahadev.
you.
Thank
Thank
you,
you.
everyone.
Mohit.
Thank you,
Thank you,
Doctor.
everyone.
Thank you, Mudit.
Thank
Thank you.
you. Thank
Thank
you.
you.
Yeah. Bye, everyone.
Thank you.
Good night.
Goodbye. Good night.